So coming back to the bone marrow, I just want to say I agree that we should really try to get bone marrow biopsies. A lot of docs will hang their hat on a JAK2 mutation, and we have to really be careful about that, given that about 10% of people over the age of 65 will have a mutation in a number of different genes. The fourth most common to be found is actually JAK2 at a very low allelic burden, but we might not even get that information from a panel.
I'd like to relate to this point because I came across these patients very recently. How do you deal with the patients that have some elevated hematocrit, but happens to have a very low level of JAK2, a very low quantitative level of JAK2, and the end story is he most likely has secondary polycythemia, and the JAK2 is a JAK2, just happens with age. So in a way, it's kind of a double-edged sword. JAK2 mutation is definitive diagnostical for polycythemia vera. It's positive in 98% of the patients with P. vera. Great, it's very helpful as a blood test. On the other hand, we have absolutely to create awareness for very low levels of JAK2 and not to rush to a diagnosis. You have MPN just because you have low level of JAK2. And I'm getting those patients, and it's apparently a recurrent problem now.
I've seen them too.
Yeah, that really speaks to the importance of the bone marrow to try to help determine if that MPN is present. What is interesting about that literature is that even those low, very low JAK2 allele burdens will have increased cardiovascular risk and stroke risk. So in those patients, when I see them, I am aggressively managing those factors, even if I don't think an MPN is present.
That's a critically important point about CHIP. Not only the risk of myeloid malignancies, but the risk of cardiovascular disease.
So it's emerging as an interesting topic in two ways. One, to help us a little bit not to rush into diagnosis, but on the other hand, to calculate the risk of patients that have JAK2 positivity and to start to see clinics for CHIP developing in hospitals. Actually, many hospitals are going after it.
Yes. So Moshe, as long as you have the floor, why don't you talk us through what are some of the signs that, or symptoms that patients have that indicate progression of their PV?
And so first we have to be aware that PV is a chronic disease, and people can live long time with polycythemia vera. And here was the first prognostic feature of progression that was mentioned and is not usually accounting for progression. That's elevated white count. We should not ignore it. It probably is an early sign that the disease is on the move, but it's something to keep in mind. Definitive signs of progression, well, the disease can evolve at least in two definitive patterns, one to leukemia and one to myelofibrosis. And progression to leukemia is when you start to see blast, you have to be, immature myeloid cells, you have to be concerned. I assume that the rate of transformation to leukemia is about 10% in 10 years, more or less. It's still debatable figures. The rate of transformation to myelofibrosis is higher, and maybe 20% in 10 years. And what we start to see is what has been called classically as the spent phase, where the patients start to develop a change in the pattern of the disease. Instead of having high hemoglobin, they start to have anemia. They start to have change in the blood counts. Immature cells start to show up in the blood. Atypical forms of the red cells start to show up in the blood. And the patient may have developed new set of symptoms. At that point, you start to be concerned that the disease is switching. Of course, bone marrow is helpful as well, although I want to make a distinction between bone marrow fibrosis and myelofibrosis. Bone marrow fibrosis, almost all patients with essential thrombocythemia and polycythemia have what the pathologists like to call MF1. Transition to MF2 and further starts to suggest that the patients have more reticulin and begin to have collagen fibrosis, and those are indication of transition to myelofibrosis.
Okay. So Moshe kind of focused on a lot of the laboratory and clinical feature, laboratory and bone marrow features, but how about symptoms? Robin?
Yeah, we've done a few analysis of this too. When patients have progressive disease, we have to make kind of a distinction first of progressive disease versus transformation, because they although they can be the same thing, a lot of times they actually are a little bit different. It is that increasing white blood cell count. It is those early precursors. But most of all, in my practice, I see patients usually with worsening symptoms. A lot of times that can be related back to a thrombotic event or worsening splenomegaly. But sometimes they can't. Sometimes it's just worsening of constitutional symptoms, worsening of itching or things like that. And certainly you want to go back and make sure you're managing the different aspects of PV as best you can, but it also might make you want to go back and say, okay, am I sure that, that this patient isn't transforming, or are there elements of this progression that I might be able to treat more aggressively? So especially if I do see a patient with unremitting symptoms and increasing white blood cell count, that is a time where I will consider increasing cytoreduction, potentially trying to change therapies.
But even if you do use cytoreduction, a lot of times those patients remain symptomatic.
It's true, and we've done those studies where even on hydroxyurea, we actually can see increasing symptom burden on people on hydrea versus not on hydrea. With phlebotomies, over time, we'll see increasing symptoms of iron deficiency, so fatigue, cognitive issues, restless leg symptoms, interferon flu-like effects. So in general, I do think that it's really important that when we're evaluating a patient that we try to pick a therapy based on what would be most beneficial for the patient as well as their thrombotic risk and blood counts.
Okay,